So as we're getting close to the end of our future programming, we have Dr. Brendan Leier, who is going to chat with us about why he's hopeful about the future of the medical humanities. And so he has sent me one of the most interesting descriptions of a talk that I've ever received. So he said, 20 years ago, a handful of physicians at the Royal Alex Hospital undertook an REB unapproved study involving the release of an ape into the hospital community for 12 months. 20 years later, the same ape will reflect on his interactions with human doctors and whether any semblance of humanity remains in medicine. So I'm going to share some slides here.
I'll set this up so there's minimal beard interference. Thanks. That was a very cheeky thing. I forgot I sent that. So I use the term optimistic in here because my character is not necessarily one that emanates optimism. So I'm happy to at least for once in my life, discuss optimism. And I will then now temper that with the rest of this talk. So I just got back from the Alberta Psychiatry Conference, their yearly conference they have. And after I was in a debate there, and after a bunch of young psychiatrists gathered around who I'd taught at some point. So just new staff and senior residents and people like that. And I always love those times because you see these people and then they sort of go off in the world and you don't necessarily keep in touch, and then they sort of reappear. It's like lovely to hear about them. And it was funny because they're all sitting around and I said, so are you guys all happy now that you are staff physicians and you know exactly what's going on? You're perfectly comfortable and competent? They're like, no, it's even worse now. And I'm like, well, what did I tell you? But you have mixed messages in medicine. And I was very, very privileged to be a clinical ethicist in the University of Alberta Hospital for 20 years. And the nice thing about that is that medicine is very much like sort of works inside of healthcare. Healthcare is hierarchical and tribalistic. But when you are a clinical ethicist, no one knows who you are or actually what you do. And so you can have very candid conversations with people, and especially physicians are remarkably transparent of what they think, what their challenges are. And so I basically, as much as being trained as a philosopher, as much as I like to endorse the social sciences or any of their methodology, I very much enjoyed being an anthropologist, for 2 decades, being able to sit very, very close to medicine and sometimes inside medicine, but from an outsider's perspective. And I noticed very early on that as undergraduates, you receive these sort of bizarre endorsements of how good you are and how lucky you are to be accepted into medical school, and how you're the best of the best, and literally absurd sort of things like that. And then spend the rest of your undergraduate career having your sort of incompetency sometimes demonstrated in front of groups, not feeling particularly confident or competent, and being exercised in such a way as that, there's always this promissory note. Don't worry, when you're finished this, you'll be good to go. This is why you have to do this. As soon as you're done your residency, then you're going to be good to go. As soon as you have a staff job, then you're going to be good to go. And feeling myself, having gone through the same sort of thing in graduate school, there's never a moment, I remember handing in my dissertation, and I'm thinking, there should be some like good feeling accompanying like this wave of endorphins, but it was just like arguing with someone about the margins being a millimeter off. I'm just thinking to myself, if I throw this through the window, I won't get my dissertation. and then just having to supplicate myself yet one more time to sort of make things work out. So there's this an interesting sort of tension, interesting set of mixed messages. And what I'm going to suggest in my talk, and why I'm hopeful about the humanities, is that the thesis of my talk is that there are probably 4 things that are going to be most important for you to learn that you won't learn in your medical education. There's lots of different reasons for that. My colleague Peter Brindley, who is probably most famous for his excellent use of hilarious slides, and I'm not sure if he like cruises social media all day, but I won't speak with him anymore because the slides are just that great. He has a lot of good liners as well. And he said to me one time, when I was complaining about the lack of ethics and humanities education in medicine, he said, "What you've got to realize, Brendan, is that the undergraduate medical curriculum is a beast with 1,000 mouths and no anus." So it's tough, and I agree with Michael. The real teachable moments are at the very beginning of your clinical work, when you haven't become institutionalized, and things that make you feel awful, you don't have to rationalize and push to the side. So there's sort of like any therapy, right? There's a very important time where you need to integrate your emotions. And if you don't do that, then there are certain risks associated with that. So Richard Taylor, the beekeeper and philosopher, writes this wonderful book in the early 70s, basically ending his career as an analytic philosopher. And in it, he describes basically 2 different questions about ethics. He summarizes as whatever, the history of ethics boils down to asking these 2 questions: what makes right actions right, and what is the good life? And so if you look at contemporary ethics, and I will talk about ethics, but that's really just a reduction. I'm much more interested in the philosophy of medicine than in ethics per se. So much of contemporary sort of neoliberal bioethics and ethics in general is concerned about this question about particular actions and what the justifications of them are. Medicine, and that's important for medicine too, but the really important question, the starting point of medicine, is this older question of what is the good life, the sort of question that we would refer to as eudaimonia, that the Greeks asked, right? And this was the central focus of the way the Greeks thought about philosophy and about the world and about their lives. As a matter of fact, the first question doesn't even occur. You can scour everything that we have remaining from ancient philosophy, and no one cares to suggest, or no one even cares to muse about the constituents of the properties of correct action. If you're a good person, then the things that you do are going to be good. So the essence, the important question for medicine, and medicine is really at a crossroads, because the question of what is a good doctor has always been at the core of medicine since the Hippocratic tradition begins, right? And a lot of the transition, the sort of paradigm shift between from the Hippocratic tradition and in modern ethics, the emphasis on patient-centered care, what patients' rights are, what they can come to expect. That a lot of that transition has sort of, unfortunately, the core of Hippocratic ethics has been thrown out as a sort of system of ingrained paternalism, which is very unfortunate, because it leads us at a sort of a second problem that I'll discuss in just a second. So the most important question in your life, regardless who you are, so who am I and what should I do? And when you start in medical school, then you're accepted into a very long, you become the sort of steward of a tradition, a 2,000-year-old tradition, that at its core, like all professionals, at its core, you know, the most relevant question is, what is it to be a good doctor? And as that boils down, the most important thing that comes out of that is that you need to be able to advocate for your patient, right? This is the essence of the sort of fiduciary relationship, and that's what makes professionals true professionals. But advocating for your patient, when you sort of unpack that concept, becomes very, 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 very complicated. It's very interesting, but very complicated, because sometimes your patients will make decisions that are not in their best interest, and clearly not in their best interest. There's kind of two ways you can go on that. One of the ways, unfortunately, is the sort of radicalization of medicine into, and if you don't have to look far for evidence of this, you know, in the Canadian bioethics literature, a lot of Canadian bioethicists are so upset that physicians would still believe that they should be able to pick and choose the kinds of things that they offer to their patients, the kinds of procedures that they're going to offer to their patients, because we grew up in this milieu, which is a combination of two things: sort of radical freedom. So as Canadians, we're born, we can practice any religion we want, we can choose any sort of form of what you consider the good life, what kinds of values you have, what kinds of things to pursue. And yet the first question of what is the good life, this eudaimonistic question, is completely absent from public discourse, completely absent from education. And we sort of inherit, basically, the value of the society that we happen to live in, sort of neoliberal conservative values, which are basically the values of consumerism. So medicine is at a crossroads, because if you sort of look at the American model about the path that you probably don't want to go down, it's very, very difficult for physicians to exercise independently and autonomously when their patients are considered consumers. When they ask for something, your obligation as basically as a merchant is to provide it for them. And so there's very much a consumer element in that ethos of medicine. The other option is to maintain a sort of air of professionalism, where at its core is still patient advocacy, but understanding that you have a responsibility not to just read what your patient has written on the order form, but to understand what they need, what they want, why they want it. And so the things I'll discuss today are really tools that exist inside of humanities to reveal answers to these complex problems that you're not going to receive in your medical education, but that are going to be the key absolute necessities moving forward. The other part of the crossroads is that the superpowers of medical professionals, you know, used to be, having these bizarre eidetic memories and knowledge of obscure and arcane facts that were ready to hand, and an understanding and a training through years and years and years of experience, and basically brute force intellect, having these facts at your fingertips. And that superpower has kind of been replaced by a cell phone. So anyone now has access to these things. And as I'm told, ChatGPT 3 does a very nice job of writing up differential diagnoses and sometimes even psychiatric reports. I'm not sure how to unpack that. But the most important things, the most important things to you are going to be the nuanced sophisticated ways in which you understand how you can be an advocate and what an essential role that is. So my friend Trevor, who's usually very lazy and won't do anything for me, was in Mexico. And I said, go to the pharmacy and take a picture of whatever sign is there. And I knew there'd be a sign exactly like this. So this is one sort of model of medicine where you can literally go to the pharmacy and buy human growth hormone and take it as you will, and painkillers and diet pills and Viagra, and lots of stuff that I don't, and crafts and gifts if that's your bag as well. But I was in Mexico for the first time in 20 years, a couple of years ago, and I remember looking at a page like this. I'm like, I'm here. I'm there to get some antibiotics for my poor wife, whose holiday is being ruined by green phlegm. I looked over at my friend. I'm like, do you want to do a couple of cycles of steroids while we're here? And he goes, no, probably not. I'm like, are you sure? Oh, okay. So it's very interesting, right? And it's becoming more and more pronounced, the arguments from outside of medicine exactly about what Canadian physicians should and shouldn't do and how they should practice. These used to be veiled suggestions, and now they're ostensive, clear criticisms. But of course, the one thing that medicine still has going for it is having the capacity as true professionals, to have a very clear sense of what exactly it is to be an excellent physician, and independence and autonomy to be able to execute that. So how can you help? As a physician who can truly advocate, you need to overcome barriers using skills and knowledge that you will most likely not learn. And many physicians will never learn them. And so these are basically things that I've observed that are fundamental skills, attributes of an excellent physician, that aren't ostensibly present in the undergraduate curriculum. And if you are lucky, you'll run into people that you will learn these things from, or have them modeled to you. And if you're unlucky, then you won't. So I'm just going to go through them very quickly, explain what I think they are, and sort of elucidate as I go along. So decision-making under uncertainty characterizes everything that we do in healthcare, right? As a matter of fact, language that implies certainty, languages like cure, language like futility, are probably terms that should be banished from clinical practice. So the essence of decision-making, the essence of medicine, is uncertainty. Now, human beings are interesting because we have developed over many thousands and millions of years capacities to make decisions and tendencies in making decisions that either can be slow or calculative, or very quick and dirty. And we need both of those things in our lives. But the interesting thing is that there is an entire literature that describes flaws in decision-making under uncertainty, and describes what those look like, and who is vulnerable to them. And generally, they're referred to as cognitive biases. It's a great name. And what I love about cognitive biases are that they are profoundly egalitarian. So some people when I hear some people talk about cognitive bias in medicine, they're complaining about how bad their patients are at making decisions. And I love the fact that cognitive biases are profoundly egalitarian, so much so that any single person, regardless of education, regardless of discipline, unless they learn to avoid these things specifically and understand what they are, will admit to them perfectly, regardless of education, regardless of training, Unless you know to avoid these things specifically, then you are vulnerable to them. So cognitive biases are something as a physician that if you don't understand them, then you will make mistakes. If you don't understand how your patients are vulnerable to them, then you will find it incredibly difficult being an appropriate advocate if you can't lead them through decision-making like this. Now, many of you think to yourself, what are you talking about? I just got into medical school. How can you suggest that I have any inherent bias or flaw in my capacity to reason? Well, hopefully demonstrate that to you very shortly. So cognitive biases initially were referred to as heuristics or rules of thumb that basically allow us to make quick decisions so is that thing a thing that can eat me, or is that thing a thing I can eat? You need to make that decision very quickly. You can't get out a telescope. You can't devise a system of inquiry. You have to make these snap decisions. And originally they were described as heuristics. Now this is described much more as a set of or a fundamental underlying set of dual systems that we have about decision-making under uncertainty. One, as Daniel Kahneman refers to it, as a slow process that is deliberative, that's systematic, and then another one, a fast process that we have to make decisions quickly, but we also are vulnerable to errors. So I don't like to use the term genius. I think it's well overused, but these two fellows, in my mind, they're sort of Noam Chomsky would be one, and Daniel Kahneman and Amos Tversky would be the other. And again, these Kahneman actually won the Nobel Prize for this work, and both of them would have won it, but Tversky actually died somewhere along the way. But this, if you want to look at one of the true bromances of science, this is the one that you would look at. These guys, Tversky was in Israel and Kahneman was in New York, and they worked together in this incredibly powerful, influential field, basically inventing the field themselves with this initial paper in '74. So what is a cognitive bias? Bias from what? In order to suggest something is a bias, first of all, there has to be some kind of objective normative standard that constitutes the goodness of decision-making that you can be biased from. And there are cognitive biases that admit existence in all of the different ways that we can consider we make what a good argument is. The goodness of an argument just means, is this argument convincing? But there are different subtle ways that we do that, right? Deductive arguments, we have which are sort of Socrates is a man, all men are mortal, therefore Socrates is mortal. Deductive reasoning, for an argument to be valid, the premises have to be true, the conclusion's true, right? Inductive reasoning is just sampling, basically. And abductive reasoning is something we don't talk too much about in medicine, but it very much is a huge part of medicine. Abduction, sometimes referred to as inference to the best explanation, is basically an argument where you posit the existence of an unobserved or unobservable entity to explain a set of circumstances that you actually can observe. So Mendel was the perfect example of that. So he does the experiments with the peas, and at the end of these things, he says there must be some single property inside of these peas that is responsible for these inherited properties, right? Of course, at the time, he has no microscopes, but he posits the existence of this unobservable entity, and then years and years later, his reasoning is sort of played out. We do this in medicine all the time, right? Patient spikes a fever, ICU. They don't know, they say, okay, this person must have an infection. We have to treat them according to X, Y, Z. You don't know where the infection is. You just assume all these clinical markers. that this person has an infection and treat them like that. So that's another example of abductive reasoning. So there are standards of what good reasoning is, and biases are going to be a variation from that. So I'm just going to go through a few, and this is in an effort to humble yourself. And if you come out of this not humbled, then my congratulations to you. Because I still get caught in all these stupid things, and I get really angry because it's something I actually do. So the conjunction fallacy. Linda's a 31-year-old, single, outspoken, and very bright. She majored in philosophy. As a student, she was deeply concerned about issues of discrimination and social justice. She also participated in anti-nuclear demonstrations. So which of the following statements is more probable? Linda is a bank teller, or Linda is a bank teller and active in the feminist movement? Think to yourself, which of these statements is more probable? Now, by the very definition of conjunction, we know that that the likelihood of any conjunction is less than any one of the either of its single propositions, right? And yet people are compelled to choose number two here. The framing effect, and the next ones that I'm going to discuss. There's a wonderful list of cognitive biases now. And the other thing I failed to mention is that cognitive biases are also empirical. They have to be identifiable in groups of people systematically. And now I think the list is well over 100. And some of them are just absolutely fascinating. The ones I'm talking about here are the core ones, and the most likely to affect your decision-making as a physician. So the framing effect is a cognitive bias in which people react differently to a particular choice depending on whether it's presented as a loss or a gain. People tend to avoid risk when a positive frame is presented, but seek risk when a negative frame is presented. So here's an example of how we use framing, or how framing can affect decision-making in medicine. So all surgical literature describes surgical outcomes in a survival frame. So they will say the likelihood that you are going to survive the surgery is X% at 1 year, and then X% at 7 years. The flip side of the survival frame is the mortality frame. What they don't say is that if you have the surgery, you are likely to be dead, 80% likelihood of being dead this year, and then 95% likelihood of being dead 5 years from now. So why does this make a difference? If the numbers are the same, why would it make a difference? I'm going to describe here the brilliant work that Kahneman and Tversky did with using oncology and surgery compared. And they didn't use ordinary schmoes. The subjects of this were surgeons and oncologists, okay, in their initial experiment. And so they ran this experiment to run the data. So these people are experts. They should know, they shouldn't be influenced by the change in a frame. But here's the experiment they run. Of 100 people having surgery, 90 live through the postoperative period, 68 are alive at the end of the first year, and 34 are alive at the end of 5 years. Radiation therapy, of 100 people having radiation therapy, all live through the treatment, 77 are alive at the end of 1 year, and 22 are alive at the end of years. Okay, so this is the first sort of question. There's a first questionnaire or vignette they run between a group of oncologists and surgeons. And then they say, which option would you prefer? And of course, you would think that the surgeons would choose surgery and the oncologists would choose the medical intervention. And then they did the same thing, but used a mortality frame. And they said, of surgery, 100 people who have surgery, 10 are going to die during the surgery or the postoperative period, 32 by the end of the first year, and 66 die by the end of 5 years. And of radiation therapy, of 100 people having radiation therapy, none die during treatment, 23 die by the end of the year, and 78 die by 5 years. And so the inconsequential difference in formulating between a survival frame and a mortality frame the overall percentage of respondents who favored radiation therapy rose from 18% in the survival frame to 44% in the mortality frame. The advantage of radiation therapy over surgery evidently loomed larger when it stated reduction of a risk of immediate death from 10% to 0%, rather than an increase of 90% to 100%. So the framing effect was not smaller for the experienced physicians or for statistically sophisticated business students than it was for a group of clinical patients. So everyone learns about consent the first year of medicine. Consent is supposed to be, you're supposed to fulfill 3 criteria, right? Disclosure of harms, outcomes, patient's supposed to have capacity to understand, supposed to be free. Here's an interesting question. Is it manipulative of a physician when describing the risks or the harms of an intervention to a patient, choosing to use a survival frame instead of a mortality frame? Is that a form of manipulation? And should we be asking that question? Because we know, even for professionals, it's incredibly influential how you frame the problem. Still an open question that if I wasn't so lazy, I would have written a paper about this a couple years ago. Anchoring. Anchoring is the most powerful cognitive bias of them all. When anchoring is so powerful that you can give people a lecture on anchoring for an hour and then put them through a set of tasks and they still admit to the anchoring bias. It is almost impossible to refute or to get rid of. And this is a wonderful example. Even when even when the numbers of the original frame are irrelevant or absurd, the effect still takes place. So the question was Gandhi, this is another audience participation. Gandhi older or younger than 9 years old when he died? Older. So guess how old he was when he died? Assuming that not all of you will know off the tip of your tongues. Okay. Second question. Was Gandhi older or younger than 140 when he died? Yeah. How old was he when he died? So how do you think these completely irrelevant anchors affect people's guesses? The average answer when you ask people, the very first one, they guessed 50 years old when he died, the second 67. So that's how powerful this effect is, that even if you start off with completely absurd anchors, it will still affect your decision. This is a really wonderful and elegant demonstration. Anchoring, we have to worry about anchoring because the people who really understand the bias literature were initially, I was exposed to this literature when I was a kid and doing a master's degree, working for, doing some research for an engineer that was in environmental engineering. And it was they were all worried about how the government communicates with the population about the risk of pollution. And all of this early literature was funded, much of it was funded by the US government and the nuclear regulatory agencies, because they would say, why are people so irrational? You know, we want to put, you know, an incinerator in these nice people's backyards. And suddenly they're all getting hysterical about how dangerous they are, when we can clearly demonstrate to them that it's not dangerous, right? And so this was this was the early one of the early models of risk communication, experts to lay people. Now that may seem similar to another model of communication in medicine, right? And what do they find out? This is a terrible model to communicate risk. And the best way to have people not trust you is to assume this posture. I'm an expert, you're a layperson, listen to what I have to say. But the early work was done because people seem to be irrational, right? The human beings seem to demonstrate the inability to adapt their behavior to avoid dreadful risks. So if you live on the Mississippi River and you have one of 20-year floods and your house washes away and you get your insurance money, where do people rebuild their house? exactly where it was before. Don't want to make fun of Southern people in America. If you live in Calgary, and you know, after the late 1800s, when real estate developers started getting into politics, and all of the rules about building your house on a floodplain were sort of washed away. Where do people rebuild their houses when they all wash away? Exactly where they were before, right? So, what we need to worry about is that there are a bunch of people in the world, like advertisers, say for instance, who know exactly how these things work, who are experts in not communicating risks, but in manipulating the biases, our inherent biases. The grocery store example. So grocery store wants to sell a big, large shipment of tomato soup. They make a sign that says limit 12 per customer. And the scenario 2, they have no sign. So no sign, 50% of the customers bought 1 or 2 cans. With a sign, the majority of customers bought 4 to 10 cans. No customer bought 1 can. So if you want to, I don't want to give you all trigger your post-traumatic stress, but you might recall a time when you couldn't buy toilet paper, so wipe your ass because of similar thinkings like this. And if you want to look back at a time where both patients and medicine unconscionably admitted to cognitive biases, you could write an entire textbook just in the last 2 years of communication over COVID. Anchoring. This is a terrible one, and I use this example because, and I use it an American example because there are so many Canadian examples that I don't want to identify any particular one. He was sprawled out on the floor of his apartment, surrounded by empty beer bottles and wine bottles. EMS broke down the door. He was 63, and his elderly mother still kept tabs on him. When he hadn't answered the phone in 3 days, she called 911. He was an alcoholic, she told EMS. But after many admissions to the hospital for alcohol withdrawal, he was otherwise healthy. So the availability heuristic is a mental shortcut that occurs. People make judgments about the probability of events just because of how easy it is to think of examples. The availability heuristic operates on the notion that if something can be recalled, it must be important, and the availability of consequences associated with an action is positively related to perceptions, the magnitude, the consequences of that actions. So in other words, it's easier to recall consequences of something when the greater we perceive these consequences to be. Now, you could probably call to mind one of the, handful of tragedies in the last couple of years where, especially of people, Indigenous people in Canada, and other observable minorities presenting to an emergency room, being incoherent. The police pick someone up who's completely incoherent. If they're Aboriginal, they're more likely to be thrown into the drunk tank than taken to emergency or worked up for some kind of neurological condition or for complications of diabetes. So there are, I could just thinking right now, I could think of 5 different examples in the last couple of years where people have died because either first responders or people in emergency make assumptions about the presentation of a patient without doing due diligence, assuming that they are A, B, or C when something else is actually going on. So, and this is the pitfall, as Michael will tell you, of being a physician, because you need to have some kinds of rules of thumb to be able to work your way through problems quickly and efficiently. But the missing of a simple or straightforward thing or making one bad assumption can really ruin your day. And obviously the burden of that is paid for by the people you're taking care of. So understanding cognitive biases, understanding how decision-making under uncertainty needs to be done in the context of a discussion, not between an expert and a layperson, but a conversation between experts, medical experts on the one hand, but on the other hand, experts in what are the values of my life, what kinds of things I believe are important to me, what my dread fears are, what my risk personality is like, whether I'm a risk taker or a risk avoider. And it's only inside this context that key elements that could end in bad outcomes are revealed or not. So I can tell a story right now, just looking at the time. Let me continue on. It's a good story, but continue on. So death and dying is something I've been working on the last couple of years, thinking about for a long time, but is at the tip of my tongue because I've been doing a lot of work on it in recent times. So this is a huge issue in medicine. And so some of the things that I'm talking about are things you need to know to understand your patients. Some of them are things you need to know to understand yourself, so you can ground yourself and actually be comfortable and have some sense about the meaning of things, the meaning of death in particular to you, and understanding some things that aren't always discussed as sort of generalities or attributes of thinking, of death thinking in the general population that probably need to be sort of fleshed out slightly more. And I only came to this conclusion in the last year or so. A lot of it went back to my training as is Michael. I'm very influenced by phenomenology and still consider myself to be have phenomenological sensibilities in some respect. And one of the most influential philosophers in that tradition, Martin Heidegger, who was kind of a prick in other ways of his life, but did some incredibly influential work. It's very difficult. A lot of people don't talk about Heidegger now because of his sordid past in general, misanthropic tendencies, but his impact on Western thought is even still very difficult to calculate. So Heidegger understands in his sort of seminal book called Being in Time, decides that he needs to figure out what humanhood actually looks like, what it is for, we have this sort of Cartesian tradition where we talk about subjects and objects and minds and bodies. And Heidegger sort of says, if we start from the beginning, don't use any of that terminology because it's too philosophically laden and it implies too many things philosophically. Heidegger says we need to figure out what it is to be a human being in the world. Clearly, we are not, as philosophers sometimes describe us, these sort of disassociated entities living in a fishbowl that can talk about their beliefs and their attitudes as if they sort of as if they could somehow conceptually pull themselves outside of the world. So he says, we have to think of ourselves as fundamentally embodied in a world, and there's no way that you can pull yourself away from that. So we're embodied in a world, we're embodied in time, and the way that we interact with the world is a sort of form of care. And he says, like the dual process thinking in that we talked about in cognitive bias, there is a sort of dual process of existing in the world authentically and inauthentically. And Heidegger says doesn't use those terms in any way that's sort of value laden. He says these are just two different comportments. And when we think inauthentically, we somehow separate ourselves and we don't think about future events. We don't think about the limitations of our lives with respect to those things. It's only through an authentic mode of thought that we realize that our death is absolutely inevitable, and that will be the culmination of all of our lifetime's activities, but the limits of our activities. And he says the interesting thing about death is that your death is always your own death, and that everyone who surrounds you, that your death is just another event in their lives, like the next Super Bowl or like they're shopping on Thursday. And that interaction between the dying person and those surrounding the dying is very, very interesting, because they are really talking about two different things. And fundamentally, one of our strategies to avoid thinking about death is to assume the perspective from outside that everyone else is talking about, right? So your death is your own, but your death for someone else is just another thing. And so Heidegger says we have the capacity to flip between these two modes of being in the world: an authentic mode where we recognize the meaningfulness of our death, and that we always have an anxiety, a fundamental anxiety towards that, or a way that disengages us from that anxiety, but is also inauthentic. It doesn't help us at some point to be disengaged. So that the Heidegger's word for human being is Dasein, which means being, literally means being there, which is what he says that we always are. Right? So it's always and ever aware of its own death as a temporal being, seeing backwards and forwards, right? And that where death is a finality of its projects and potentials. Heidegger does something very clever here. And I remember getting a tingle up my spine when I was rereading Being in Time after I started working in the hospital. I remember going over these passages. I'm like, oh my God, he is describing literally every death, every scene surrounding, discussion surrounding death and dying I've ever seen in the hospital. So Heidegger refers to those surrounding and interacting with the person who's dying as the they. And he says the responsibility of the they to engage in what Heidegger refers to as idle chatter to distract the dying person from his or her attention from an authentic attunement towards death. So the very first ethics consultation I ever had that I did on my own was this old Italian man who was one of these beautiful patriarchs of the Edmonton, one of the core Edmonton Italian families, lived like a block away from Spinelli's. Whole family was there. And these two eldest sons approached me as soon as I came in the room. They like, we're Italians. We don't tell bad news. We don't talk about death. So my dad's dying of cancer. You don't talk to him about cancer. You don't talk to him. Don't tell him that he's dying. And I thought that was interesting. And they're like, we're Catholics. And I said, oh, that's interesting. I'm Catholic too. But you actually should talk about death, right? And so I had that consult about 200 more times, and in every substitute Italian for we're Lebanese, we don't talk about death. We're Chinese, we don't talk about death, right? And so the they-ness of the family and those surrounding the dying person, they feel that their job is to protect them from knowing this, and that somehow this protection is kind or benevolent. But of course, you know, and it's Michael will always affirm this being a pediatrician, there are very few people who are missing this message, right? Thinking that you've lived, all of your friends are dead, and that somehow you're, you know, you're not thinking about dying because your family's not talking about it. And Michael will attest that even small children tragically sometimes end up being the parents of their parents, because their parents say, we don't want you talking about this kid dying, right? And the kid saying, okay, you know, I'm going to go along with this story so my parents feel okay, right? So this is something that we are remarkably bad at through no fault of our own, I think, because we have sort of failed to recognize the fundamental psychological, philosophical attributes that are at play here. And we fall into the trap where cultural sensitivity is sort of trigger us, is supposed to be a trigger in us to say, shut up, don't say anything about this, don't press. But of course, if you're if you're an advocate for your patient, the real question is, doesn't every single person in the world need to know the truth about their own health and the truth about their own condition, so they themselves can decide whether or not to engage in this authentic decision-making towards their own death. So it was very tough to see these things in my job as a clinical ethicist, but even tougher because I was sort of ripped into the world from the loins of a nurse, and my grandmothers were nurses. My mom was a nurse. I ended up marrying a nurse, unassociated. She wasn't a nurse when I married her, but is a palliative care nurse. And so I know how people die in the community. I hear about 5 different deaths every day, right? And this is an ongoing theme. And as a caregiver, you struggle because you go, my wife will go into someone's home, kids will say, this old person will be like, well, do they have capacity, right? This is the big question about capacity. So this old guy saying, why is my medication changing? What the hell's going on here? And they say, Dad, he's very aggravated, right? Don't talk to him about anything. We just need to give him something to settle him down. And the dad's saying, what's going on here? Why is my medication changing? Why aren't I going back into the hospital, right? And everyone else saying, absolutely, talking about something else, distracting him. And then they die. They die a day later, they die 2 days later, never having the opportunity to say, I love you to their family, to apologize. So, sorry, thinking about something else as well. So for Heidegger, the evasion of death, which covers over and dominates everydayness so stubbornly that in being with another, the neighbors often try to convince the dying person he will escape death or soon return to the tranquilized everydayness of the world taken care of. This concern has the intention of thus comforting the dying person. It wants to bring him back to personhood by helping him to veil completely his own most non-relationable possibility, death. Thus, they make sure the constant tranquilization about death, but basically this tranquilization is not for the dying person, but just as much for those who are comforting him. And even in the case of a demise, publicness is still not to be disturbed and made uneasy by the event and the carefreeness it is made sure of. Indeed, the dying of others is seen as a social inconvenience, if not downright tactlessness, from which publicness should be spared. So the distraction is not malevolent, nor is authentic attunement of value. They're rather psychological and interrelational structures of human existence. Brendan's death does not refer to the same event experienced by Brendan and his loved ones. There are 2 ontologically different experiences. One is the experience of a death similar to any other, one precedes and follows a death, the birthday, the Grey Cup. The other is the experience of the ultimate end of all the projects, relationships, possibilities, an experience that I can turn away from. But it goes further than this. There's a wonderful Canadian palliative care writer who was a social worker named Stephen Jenkinson, and he has a book called I'm failing to recall the name. But he is a wonderful speaker. If you want to just listen to someone who understands and has wisdom about death. I guess the thing I forgot to mention is there's answers to all these things, and I'm optimistic about the humanities because there is no yet to be revealed wisdom in the world. It's all out there, right? If you don't want to read Heidegger, go read Tolstoy's The Death of Ivan Ilyich. Everything that Heidegger says in his book is in this little novella. And for the life of me, I try to get every single student I get to make to read it. but and it should be something that's more systematic. But all of this wisdom is out there, you know, and that the brilliance of the humanities is that it arrives in several different ways, right? The more and more you read, the more philosophy, more ancient philosophy you read, the more poetry you read. These are all core themes of humanity, right? Many different sources of wisdom address them in different ways. During the pandemic, I read almost every day, because it was on the back of my toilet, Marcus Aurelius's Meditations, which are basically him talking to himself. It was never meant to be a book. Basically him going through this sort of very philosophical, sort of self-talk. And the thing I took away from that was how modern a human being he was, indistinguishable. He was saying things and talking about things in a way that I could not distinguish if he lived, you know, a year ago or 5 years in the future. But he was facing the same problems, you know. 2,000 years ago, this Anatolian flu, he's in the middle of a pandemic that's killing half of the people in the world. He himself has lost, I think, 12 of his 14 or something children. All the Roman elites are acting like complete assholes. And here he is talking to himself about the simple things, but things that are grounding him, not about, geez, how am I going to handle all this, right? But here are the things that you need to do today. Here are the things that you need to think about to ground yourself, to be able to do anything, to be able to help anyone else, right? And so this wisdom exists in the world. I always like to instruct. But sometimes we get stuck. It's very easy to get stuck in one of these in an inauthentic mode where you're not paying attention to yourself, because it's easier to do stuff that way. But if you're stuck long enough in that, it's very difficult to become unstuck. And that's why, you know, even the mental exercise of reading, of thinking into things, feeling into things is so important. And I always like to make Land Rover jokes because this particular one is one of the vexations of my life. But one of the biggest problems with this model when it came out was that it had wonderful capabilities, and you just basically have to pull a knob, and then the truck can literally drive up a mountainside. But after people who bought it drove it around, and they weren't driving in mountainsides, they're driving in like parking lots. And then when it came time to actually use this knob, it was frozen in place, right? And so you end up in like this with a frozen knob. Like we often end up in life in these shitty situations with mud up to your axles and a frozen knob. So the last thing I want to talk about, do I have time? Okay. So another person, if you want to read, if you think of medicine as sort of in a sort of religious context, you have people like Michael, who literally have biblical superpowers when they talk about, when I was looking at the little babies again, I don't see them as much as Michael. So every single time I see one in person, it's like, you can't believe how how small and tiny they are. And so in the New Testament, there's this discussion about whether or not rich people can go to heaven. And the saying is, it's easier for a camel to pass through the eye of the needle than for a rich person to go to heaven. And I'm like, well, try to put a central line in a 23-week-old or 23-week born premature baby. You have these superpowers. The question is, what do you use them for, right? And what are we doing? What are we providing in medicine for people? Is it the replacement of all their worries and fears to assuage them, or are we actually taking away some of their capacities to think about things? And one of the things that in COVID made me very upset, although I learned very quickly not to discuss personal upsetness during this time, was the lack of leadership from medicine, medical experts and authorities to empower people in any way, shape or form, right? It was a very, very passive suggestion. And as I started learning more about doing more research about immunology and things like that, it's like, immune system's crazy. It reacts, it can be empowered by all sorts of different bizarre things. Going for a walk in the forest, living in the forest for a couple of days, boost your immune system by 50%. And there are all these things that in terms of self-care that would have been very simple and straightforward to empower people to do, to make them feel like they could do something. We weren't talking about, right? We're like, stay at home, do this, do that, right? But don't worry about we missed the flip side, right? We got the sickness stuff down, we missed the health stuff, right? And which for me is another dangerous tendency in medicine is to not embrace a concept of wellness and agency that, you know, everyone talks about non-compliant patients, but what we need to do better is to be able to engage in an evidence-based, very reasonable, you know, account of what you need to do to be healthy in life, right? Not what you need to do to heal your illness. If you want to look, you know, if you think that medicine is a sort of religion, if you want to look to a prophet, this is the guy, Ivan Illich, was a Roman Catholic priest who was and philosopher, who was very influential in the early 70s. When he was his very first job, he went from Austria to Brooklyn in the late 60s and realized, as a parish priest, and realized that the biggest problem in his community was that the moms, there was lots and lots of single moms, and they were uneducated, but they couldn't go to school because they had no one to take care of their children. So in his parish, he organized people to basically babysit kids of moms who wanted to go to school. And this became an incredibly successful program. And then a couple of people started complaining that this communist was living in, that they'd sent this communist to Brooklyn. And so the next place they sent Illich was in the middle of the desert in northern Mexico, and said, this is your parish now. And so he started a think tank there that's still running today. And so Illich talks about the dangers of medicine replacing and the medicalization of death. And I'm not going to read all this stuff because I want to go on to the last note. But he was basically a champion of human agency, and in his life he criticized a lot of aspects of formal education. He criticized a lot of medicalization of death and dying, and a lot of the stuff, I remember reading this when I was first training 2004, and like, holy cow, this guy is literally, the things that he's talking about come true, like a sort of Old Testament prophet. And I read this again last year, and it was even more, after I'd been in healthcare for 20 years, it was even more remarkable. So check out this, the book's called Medical Nemesis. Last thing I'm going to talk about is compassion. So this is the only tool in my toolkit when I came in to work in healthcare, because I wrote a dissertation on compassion. So I talked about it, like, it's all I could talk about, feel confident talking about for a number of years. And this is another thing, again, another problem that we see in medicine and healthcare that we've responded quite poorly to. And this is, how do you there are certain things that you need to do when you're training to be a physician, and then when you're trained to be a specialist. There's certain things you need to do that are inherently harmful to people. And this is very, very well known that human beings are inherently not disposed to harm other people, right? And until military people figured out how to systematically train their soldiers to stick a sword inside someone's abdomen, no one ever occurred to do that on a battlefield because of this inherent disposition to actually do that. So they would smash each other in the side of the head and arms and legs, right? And then go back, right? And there were very little mortality in battle, right? You know, right from the Roman and until the Romans on. The Romans were the first army to actually use their short swords and drill their soldiers to stab people in the abdomen. And they never ever fought. I don't think the Romans ever fought in a battle where they outnumbered their enemy. And yet they built an empire, basically coming up with this life hack for soldiers to actually be effectively kill other people. I remember talking to a surgeon. There's a wonderful surgeon that was at Joint Center in Toronto. He was an old guy at the time. I remember it was such a wonderful conversation because he said, Brendan, you have to be able to put these in a sense, the most fundamental emotional tendencies and prohibitions aside to be able to do what we do. You know, can't cut off someone's arm without being able to disengage yourself from what that actually looks like. It's like, imagine what a surgical field looks like. You know, now you have drapes, you don't see anything but this little square, and underneath the square is all painted orange. So it doesn't even look like flesh. So you're going in and doing this task, and the whole thing is designed to prevent you from thinking about outside of this task. Like, this is a human being, this is a person, right? And so if you're a surgeon, you can scream at your anesthesiologist if your patient's dying, and they know it's a person, right? They have other person stuff to do. Your job is to do this, right? So the question is, how much of yourself do you have to leave at the door then if you're a physician, if you have to disengage yourself from these authentic and in many ways sort of primordial emotional responses to people? And in a lot of ways, and a lot of time, I love to talk about compassion, and I hate the term empathy, because compassion is actually a natural kind. Compassion is a wonderful concept. It's one of two concepts. It's one of two values that is truly a universal value. Any culture that you look in, any historical writing, any religious tradition, compassion is a universal human value. Can anyone guess what the other one is? There's only one other one. It's ironic because it's kind of dead in our culture. Hospitality. You think of hospitality, you think of going to Earl's or to a shitty hotel room, right? That gives you slow Wi-Fi, right? Hospitality is another wonderful, rich topic. So compassion, so empathy is, in the early days, Aristotle, philosophers never really thought about compassion because compassion is an emotion, and philosophers in the Platonic and Cartesian tradition have always despised emotions, thinking them to be vestigial animal traits. And we talk about mind-body dualism. That's what we're talking about, right? But Aristotle said, well, I'm talking about everything else. I might as well spend 5 seconds to think about compassion. I have no gripe with Aristotle because he had a lot of stuff to work through. It's like, well, compassion must be, seeing someone else, they're upset, and you can imagine what they might be upset about. And then if they're similar enough to you, then you might feel sorry for them, right? And that's how compassion works. And it wasn't until the late 1800s and early 1900s where philosophers, like the early phenomenologists, said, this is not what happens at all. As a matter of fact, compassion begins with emotional contagion. You're actually feeling the suffering of another person. And that all of this happens in a very precognitive way. You don't have to think about anything. When you see someone suffering, you suffer with them. That is the sort of root of compassion. And in many ways, one of the feelings that we sometimes try and disarm. Now, in medicine, I said, you know, it's important to attend to that feeling, because that feeling is the beginning of the therapeutic relationship. Because in medicine, of all people in the world, physicians have the opportunity to be truly compassionate, because they have the skill to be able to alleviate the suffering of the person that they feel, right? And so that alleviation of that suffering, of your own suffering, is the motivation to actually help, is really the motivation, you could argue, to help anyone. And when we talk about in healthcare, we talk about things like compassion fatigue or moral distress. One of the primary source of that is, if you do a careful phenomenological sort of analysis of it, is basically the failure to be able to satiate that emotion, right? It's like being hungry and not being able to eat. You know, that's the feeling of compassion fatigue. If for some reason you're in a situation where you're engaged in a therapeutic relationship but actually can't help your patient, that is exactly the same as going to bed hungry. The philosopher Diogenes of Sinope thought a lot about these things. Diogenes the dog, he was one of the first cynics that they sort of turned into Stoics, but he was also the king of the one-liners. So he said, when he was caught one time masturbating in the public square and reproached, he said, if only I could rub my belly to alleviate my hunger, then I would do that as well. So he, of all people, sort of recognized the importance of satiating these emotions, and that being the core. But you know, the interesting thing about the ground of ethics, and this is the last thing I'll say, the ground of ethics is that even the Greeks, the ethics wasn't some esoteric, deep position where we could make assessments on the correctness of action from, you know, the perspective of nowhere, right? If you look at where the term ethos comes from, it just means convention or habit, right? So the ethos of a Athenian was different than the ethos of a Spartan, right? There was incredible conventionality built into it. But Heidegger suggests there's an older sense where ethos means to abode, right? An abode or a dwelling place. And the word names the open region in which human beings dwell. The open region of his abode allows what pertains to the essence of a human being, and thus what arriving resides in nearest to him to appear. So it's this, again, this authenticity for Heidegger is the most proper thing to us. And physicians need to attend to their practice in such a way that compassion is burning within them. It's not something that you put on the shelf. There's wonderful, terrible papers that are written about compassion when you look in what medical students, there's this great one. It's like why I am less compassionate as a fourth-year medical student than when I came in. And I think that's like that sense was so atrocious that they tried to repeat it. And there's lots of different stuff that follows along. But this is the feeling, right? That somehow this is being trained out of you. And that when you're done, I don't know what exactly, then you're supposed to behave with empathy, which is pretending that you are sort of going along, you know, and understanding, paying attention and sort of trying to intellectualize yourself into what others are feeling. I remember having a very disturbing conversation with someone very high up in AHS about something that had happened. And this person said to me, "Oh, Brendan, you must be really upset. You know, you've known that person for a long time. Yeah, it must be really upsetting to you that this is happening." I'm like, "Are you active listening me?" And then I was just crestfallen. And then I'm like, "Oh my God, right? This person's not even listening to what I'm saying, right? It's just managing my emotions." And I remember being I remember the sort of bottom dropping out, and I was like, oh my God, well, it's no use having this conversation, right? And so it's dangerous pretending to care about people, because people aren't stupid, right? And we have resonate on this at such a fundamental level. Okay, that's all I'm going to say. So the last thing, wisdom is really a mix mash of everything. Everything that we've talked about. The last thing I'll say about wisdom, and then I'll shut up, is this wonderful Zen parable where an abbot of a monastery is standing outside, and this young novitiate comes and stands beside him, and they're looking at this deer. And the young novitiate believes like he's in a Zen moment with this abbot, beholding this nature. And the abbot reaches down and picks up a stone and whips it at the deer and pegs the deer, and the deer goes running off into the forest. And this novitiate's like, he's just outraged. He's like, what all you talk about day and night is compassion. Why would you begrudge that deer nibbling grass in front of us? And the abbot said, the more that deer gets used to people like you gawking at it, the more used he's going to be to human beings, and the more likely he is to be killed by a hunter. And so wisdom, and so that lesson is the wisdom that compassion needs guidance by wisdom. And those two are, for me, the cardinal virtues of medicine, right? Wisdom is understanding the causal nexus that surrounds you, not only the proper canon of medicine, but understanding what your patients look like psychologically, what they're vulnerable to, what kind of thinking they're vulnerable to, how they might not be interested in talking about certain things. And then that wisdom should guide your compassion. And compassion looks crazy sometimes, but that's the wonderful thing about it. So that's it. I think I've gone way over. So yeah, thank you very much. It's a great pleasure to be with you today. Sure. I don't know how to do anything, but I'm very happy to take some questions. Where are you guys, London? You overlooked the Clash joke, Michael, that I thought was just handed to you on a silver platter, which was London Calling. Right?
No problem.
Michael is more of a jazz guy than a punk rocker. Oh, sorry. Go ahead. Any questions from there? Yeah, okay.
Hi, great to hear from you, and thanks so much for your presentation. My name's Daniel Wazinski. I'm a ethicist at London Health Science Centre, and I'm just wondering how you personally embed humanities into ethics consultations when it can be really difficult, and people are sometimes just looking for process or kind of the quick ethics approval. So just wondering how you personally kind of embed the humanities into ethics.
Yeah, something I think I realized over about 20 years in particular that what people don't want, and people typically don't want this sort of overarching analysis, view from nowhere analysis. So I always like to give very specific advice to whoever's asking me the question. And so first, you need to put yourself in their position. So if a doctor is asking me advice, then I give them advice from their own perspective and what they need to know as a fiduciary, as a patient advocate, what their own responsibilities are. And so oftentimes I find my consultations are helping physicians come up or explicate the rationale for what they want to do. Not only considering why they want to do it, but usually what they want to do. And I found myself, what the biggest contribution to answer your question specifically is is providing a sort of teleological structure to embed medical decision-making within, so that every single decision can be justified as having a therapeutic goal, and then in principle, but then the wisdom of the decision comes in as to whether or not that decision is proportional. And I find that the principle of proportionality is something that's profoundly missing from medical education and clinical practice. So saying, we can do this, we can try and put an NG tube in this elderly demented patient. But the relevant question is, one of the things that we know very certainly is what the harm is going to be, that they'll be agitated, that they may not enjoy having a tube in their nose, that force feeding them actually might be far more burdensome. And then the question becomes, can we justify that proportionally by saying, is the therapeutic outcome that we're looking for going to be proportionally beneficial such that it will justify doing this, right? And so that context of proportionality doesn't really come from, that language doesn't come from medicine. It comes from philosophy, and it comes from theology, actually. But it's very, 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 very practical, because it allows you to avoid appeals to certainty. So the family might say, well, if she, this, and this might happen if we don't have a tube, in her. How do you know for sure it's not going to be helpful? Well, you can't honestly say as a physician anything about certainty, right? And it's best. So I find that sometimes it's helpful to use these kinds of principles and frameworks to provide physicians a set of tools where they can speak confidently as advocates about what the harms of this are and what the questionable benefits might be, and to make a good argument that also brings the family around to say, can we justify doing this, right? Because this is all clearly harmful. It's nice to say, do whatever you need, and that you hear this all the time, do whatever you need to do to prolong their life, to make, to keep them alive, et cetera, et cetera. And those conversations can get very frustrating very quick, because you find yourself at loggerheads. So I would say, yeah, the thing that's informed me the most to be helpful is being able to propose ironically a very ancient way of thinking about the world, that is no longer helpful to us doing physics, but is very helpful to us because everything that we do in healthcare should be justifiable in terms of its end goal, right? It should have a therapeutic outcome. If it doesn't have a theoretical therapeutic outcome, you should not do it. And then the question becomes, is it proportionally justifiable, right, to harm this person? And everything can be articulated in that context. Walking into the hospital is harmful, right? Getting your blood pressure taken, getting an injection, anything, right? So sometimes it's helpful to provide a sort of new playground to have this discussion in this context. And I find that families actually respond quite well to this as well, right? Because the irony is that, and the paradox is that the nurse is always going to be at the bedside. Physicians have to do this stuff. The family might not be there. They're not witnessing the burden, right, and the suffering, or someone extubating themselves and having to be tied up in the middle of the night, or chemically sedated, right? And so, yeah, so that would be my answer to that. It's nice to meet you. Thanks for the question.